Okay. Good morning, ladies and gentlemen. In the first place, I'm going to introduce myself. I am Dr. Rindodar, interventional cardiologist in Hospital General de Alicante, and with my colleagues, Dr. Borja Ibáñez, interventional cardiologist in Hospital Clínico de Madrid. We are going to moderate this session on management of ST elevation myocardial infarction. It's a pleasure for me, for us, to moderate this session with three speakers worldwide renowned. We are going to discuss three very, very different points of view about the management of treatment of the STEMI with three experts in their areas. The first item will be the reperfusion injury, and it will be reviewed by Dr. Obis. He will give us his personal vision of the importance of the reperfusion damage in our patient with STEMI. The second subject will be about an important aspect of the STEMI, young women with myocardial infarction, a very important subgroup with different presentation and clinical characteristics. And I am sure that Dr. Cruz Hall is probably the best speaker to describe this population. And finally, Dr. Van den Heuvel will be in charge of the third and last presentation, the importance of networks for the reperfusion of patients with STEMI. After this presentation, we'll have 5 minutes for questions from the audience. We are delayed. And, well, with no more delay, I'm going to pass the word to the first speaker, Dr. Michel Obis. He is cardiologist in the Louis Pradel Cardiologic Hospital in Lyon, France. He's very well known by everybody. Among his researches are notable his efforts in different aspects of cardioprotection and especially in the reperfusion injury. He will talk about cause as management of reperfusion damage during intervention for myocardial infarction with, I think, a very exciting title, The Last Frontier. Please, Dr. Obis.
Thank you very much for this introduction, and I would like to thank the organizing committee for inviting me to this very nice venue. And as you see in the title, and we have heard a lot this morning on the ischemic injury, in fact, and I would like to present some data regarding reperfusion injury, which is much less known, I guess, from the community of PCI cardiologists. And I think we have a lot to foresee and to learn about this aspect of acute coronary syndromes. Basically, we all know that the prognosis of our patients, STEMI patients, is related to the irreversible damage to the heart at the time of ischemia and reperfusion. As you can see here, we have two cartoons showing that the mortality at 6 months is directly related to infarct size on the left, and that the all-cause mortality and hospitalization for heart failure is also related to infarct size. And this is why we try to reperfuse as soon as possible STEMI patients. But we may have two targets when dealing with this type of patient. Target one is well known. This is reduction of the duration of ischemia by reperfusion therapy. But we may have another target, which is reperfusion injury, and I will try to show you that so far we have no treatment, unfortunately, to deal with this second type of injury to the heart. And there has been a lot of experimental evidence in the literature regarding reperfusion injury, but one example is what we call ischemic post-conditioning. Briefly, I can describe the experiment done more than 10 years ago now in the United States in animal models. If you look at the upper part of the slide here, you have an experimental protocol in which animals were subjected to 1 hour of ischemia by coronary artery clamping, and then reperfusion by declamping. And in the third group, the authors performed 3 cycles of brief reocclusion of the coronary artery and reperfusion. 3 cycles of 30 seconds to 1 minute of brief re-ischemia and reperfusion. And you can see that down on the left part of the slides, at the end of the experiment, when they measured infarct size, they realized that what they called post-conditioning was able to reduce infarct size by about 40%. So it means that one intervention performed at the time of reperfusion, that is after ischemia, is still able to reduce infarct size by 40%, suggesting, by the way, that 40% of the final infarct size is due to something that happens after ischemia. And this is recapitulated in this scheme, in which you see on the y-axis the final infarct size versus time on the x-axis. If you occlude the coronary artery here at the time, at the 0 time, you first have the ischemia period in which infarct size growth over the myocardium. And then at the time of your perfusion, you would expect that you stopped the extension of infarct. But in fact, when you measure infarct size at the end of the experiment, you realize that the final infarct size is larger than expected with respect to the ischemic insult, suggesting that there is an additional damage to the heart that happens at the time of reperfusion. And this is this injury that is tackled by what we call post-conditioning. And this post-conditioning effect is significant because it represents in animal models 40 to 50% of the final damage. What is the mechanism of this lethal reperfusion injury? In fact, we don't know. There are many labs in the world working on this issue, and this is just an example of a complex signaling pathways in the cells that may be involved in the mechanism of reperfusion injury. Of course, we're not going to enter in this subject, but what is important is that many of the signaling pathway seem to converge to mitochondria. Mitochondria is the powerhouse of the cell, but it also involved in death in different conditions. And one specific function in the mitochondria seems to be involved in reperfusion injury, and this function is called mitochondrial permeability transition. What is it? Basically, I represented here a mitochondria in green, and in the inner membrane of the mitochondria, there is a pore named the mitochondrial permeability transition pore, a channel, which is normally closed upon ischemia and at the time of reperfusion, when you have the accumulation of calcium and the production of reactive oxygen species in the mitochondria. This triggers the opening of this pore. And since then, there is a lot of events that may lead to cell death. And what is important to see is that this phenomenon occurs at the time of reperfusion specifically. And it seems that the opening of this pore can be blocked by ischemic post-conditioning. Many works show that. And by a drug you all know which is called cyclosporine. You probably know cyclosporine for its anti-rejection effect. But cyclosporine has a second effect when it targets mitochondria, which is to block this pore. So it's been used over the time as a tool to look at the mechanism of reperfusion injury. And based on this, what do we know of the evidence that there is, in fact, lethal reperfusion injury in STEMI patients? Is it a lab artifact, or does it exist in STEMI patients? In fact, years ago, we performed a small-size clinical trial, a phase 2 clinical trial. We had STEMI patients coming in the cath lab from less than 12 hours after the onset of chest pain. We only choose LAD patients with TME 0-1 flow at the admission and no visible collaterals on coronary angiography. And we randomized patients into two groups. In one group, on the top, there was the usual PCI procedure with direct stenting. And in the other groups, we performed what we call post-conditioning. That is, we performed the PCI normally, and then less than 1 minute after reperfusion, we reinflate the balloon upstream the stent for 1 minute, then deflate the balloon, and did that 4 times, just like we've seen before in animal models. And then, of course, we stopped and let the artery open, hopefully. And at the end of the procedure, we measured CK release over time, over 3 days in the two groups. And as you can see on the bottom of the slide, when you look at the area under the curve of the CK release over time in the two groups, you can see that the patient that had this post-conditioning intervention, in fact, had a smaller area under the curve when compared to the control group, suggesting that infarct size, if you consider the CK is able to measure infarct size, is reduced when you do post-conditioning in patients. It would suggest that lethal reperfusion injury exists in STEMI patients and that it can be alleviated by this type of intervention. Since that time, there has been many groups over the world that have performed similar studies, and here is a presentation published by Gert Heusch in The Lancet, recapitulating last year the trials that have been done in a similar settings. And in fact, if you look at the blue square, they represent the infarct size reduction seen in these trials, and you see that 10 out of 12 trials were positive, showing by ischemic post-conditioning in STEMI patient that you can reduce infarct size. So there is accumulation of phase 2 trial evidence that we can do that in patients. Infarction is not the only consequence, as you know, of ischemia reperfusion. We have at least 2 other features of reperfusion injury that are myocardial edema and no reflow, and it's been shown in clinical studies that these 2 aspects are sort of risk factors, they impact on the prognosis of our patient. And we could show in another study that, in fact, this post-conditioning intervention at the time of reperfusion is able, as you can see on the left, and as I said before, to reduce infarct size, but also to reduce myocardial edema as measured by T2-weighted MRI 2 to 5 days after reperfusion. So there is sort of an additional benefit to infarct size in this post-conditioning intervention. We also, in another trial, looked at no reflow phenomenon. In clinical practice, we all know that we can sort of assess no reflow by ST segment shift at the time of reperfusion, but we also can do MRI to measure more accurately no reflow in this patient. In this trial, we could see, it was also a phase 2 trial, that in fact post-conditioning was able, as you see on the bottom of the slide, to reduce early and late no reflow phenomenon in STEMI patients. So beyond infarct size and also associated with infarct size reduction, you can see that post-conditioning in STEMI patient can reduce myocardial edema and the no reflow phenomenon. Recently, we tried to see whether post-conditioning was interesting in a different subpopulation of STEMI patients, that is, patients that come with an open coronary artery at the time of admission. So far, we have looked at patients with STEMI 0 or 1 flow at the time of admission. And then we asked whether this could be also interesting to protect patients with STEMI 2 to 3 flow at admission. This is a different concept, in fact, because these patients are STEMI patients, meaning that at the time of first medical care, their ST segment shift, and the coronary artery is likely to be fully closed. But when they are in the cath lab and you do coronary angiography, the artery is open, meaning that the artery has been reopened spontaneously or by any drug during the transportation to a hospital. So we wanted to see whether this patient can sort of be protected by a delayed application of post-conditioning. And in fact, we saw that in that subgroup of patients, there was no protection at all, suggesting that reperfusion injury had probably occurred between the time of this spontaneous reperfusion and the time of the application of this post-conditioning intervention. This is in fact confirming experimental data in which authors have shown that in mice or rats, if you delay by more than 15 minutes the application of this post-conditioning intervention, you lose the benefit of infarct size reduction. Another aspect of conditioning intervention is what we call remote conditioning. This is a strange phenomenon that has been shown in animal models. It seems, as shown on the bottom, that if you perform brief ischemia reperfusion in episodes in one tissue or organ that is distant to the heart, you finally can protect or reduce myocardial infarction in the heart, saying that if you do ischemia in any part of the body, you would protect any other part of the body. And it's been shown specifically that if you perform the harm ischemia by inflating a blood pressure cuff several minutes or several times, you can reduce infarct size in pig models, for example. And there has been a study by a colleague, Hans-Erik Bodker, in Denmark, showing that infarct size in STEMI patient can in fact be reduced by application of this protocol, blood clot inflation, during the transplantation in the ambulance. And as you can see here on the y-axis, they measured infarct size by MRI, and they found that when it is expressed as a percentage of the total amount of ischemic tissue, it's reduced by this type of intervention. The mechanism of this remote protection is completely unknown and very strange, by the way. We performed a much smaller trial recently, and we showed that, in fact, this remote conditioning intervention cannot be additive to the benefit of the intracoronary post-conditioning intervention, suggesting that the mechanism of protection may be similar. Now, we have talking about protection against infarction by ischemia itself, but we probably can protect the heart by pharmacological intervention. And the most important aspect of that is that we have to give the drug immediately at the onset of reperfusion or before that time. Because, as we have seen before, if we suspect that it is a mitochondrial phenomenon, we have seen that this phenomenon occurs in the early minutes of reperfusion. So the drug, any drug, has to be on board at the time of reperfusion to be protective, if it is protective. In fact, we tried cyclosporine. We have seen before that cyclosporine is able to block this permeability transition pore. So we performed some years ago a phase 2 clinical trial in which we randomized patients in the cath-lab STEMI patient into two groups. One group receiving cyclosporine A injection, 2.5 milligram per K, IV bolus versus saline. And then we measured infarct size by CK or troponin I release, and in a subgroup of patients by MRI, 2 to 5 days after infarction. And this is basically what we saw in terms of cardiac enzyme release. If you look at CK release or troponin I release, those patients that receive cyclosporine at the time of reperfusion, in fact, had a much smaller infarct size than those patients who did not, suggesting that cyclosporine A is associated with an infarct size reduction in STEMI patients. Other drugs have been tried by other groups. For example, Lundberg and colleagues showed that exenatide is able to also reduce infarct size in STEMI patients, as shown here. When you measure infarct size as a percentage of the area at risk, the patient that received exenatide at the time of reperfusion have smaller infarcts than the other patients. There is a study by the group of David Garcia Dorado in Barcelona, and this study is not published yet, but he wanted to look at the potential beneficial effect of adenosine administered intracoronally at a dose of 4.5 milligram before reperfusion. You know that there has been a lot of trials with adenosine in thrombolysis, and especially the IAMCEST trials. And this is a double-blind, randomized, placebo-controlled trial. And David Garcia Dorado is measuring infarct size in these 200 STEMI patients by MRI at day 7, and we'll see soon the results. And there is, of course, our chairman's study published last year in Circulation, looking at the effect of metoprolol, the beta blockers, on top of PCI in 220 STEMI patients admitted within 6 hours of symptoms in the cath lab. And of course, as I said before, metoprolol had to be administered before reperfusion, and they looked at infarct size and LV function several days after and 6 months after the acute event. And the summary of the data regarding infarct size is presented here. In fact, they showed that the STEMI patient that received metoprolol before reperfusion had smaller infarct, as shown here, or as shown on the right part, regarding the area under the curve of CK or release over time. And recently was published, it's not shown on these slides, the follow-up study regarding 6 months later, this same cohort of patients, and they showed that in terms of events, there was a reduction in the subgroup of patients that received metoprolol of the hospitalization for heart failure and an improvement in ejection fraction, importantly. Recently, you probably saw another study by the group of Greg Stone showing that abciximab, when injected intracoronally, was able, as shown in red, to also reduce infarct size when given at the time of reperfusion. suggesting once again that if you administer a proper drug at the time of reperfusion in STEMI patient, you can probably protect the heart and reduce infarct size on top of reperfusion therapy. What is the next step? We have seen examples of phase 2 trial that are suggesting that we may have a benefit. Obviously, we need larger study. And as for cyclosporine, we just completed a phase 3 study in which we included 1,000 patients. These patients are STEMI patients, hospitalized less than 12 hours after the onset of symptoms, treated by PCI. We took only LAD patients with TIMI 0 or 1 flow and no visible collaterals, and we follow up these patients 1 year and measure a combined endpoint including death, hospitalization for heart failure, and LV remodeling, and we'll know in 9 months from now the result of this ongoing study. So to summarize, I would say that ischemic injury is well recognized and treated by reperfusion therapy in STEMI patients, as we all know. But lethal reperfusion, I hope I convince you that it is also important and represent a large amount of tissue that can be saved, and that we know from phase 2 study that we can reduce this amount of injury, and we need phase 3 trial to see whether targeting this reperfusion injury can improve clinical outcome in our patient. Thank you for your attention.
The paper is open for discussion. I think we have a first question from Dr. Harlan Krumhoff.
Thank you very much. It's a superb presentation and a very complex topic. I have a question for you, and I totally agree that we need to see a study, a phase 3 study with clinical outcomes. You put a lot of weight on infarct size, and much of the presentation is about infarct size. There's an observation that I've always had difficulty explaining, and I wonder what you think. In ISIS 2, if you look at the 10-year outcomes, the BMJ article from '98, the split is within the first 35 days. And then the survival curves are parallel for the next 10 years. Presumably, the patients who got streptokinase must have had smaller infarct size on average, the survivors, than did the ones who got placebo, or in the 2x2 factorial, some half get aspirin, half don't. But they all get placebo for reperfusion therapy. It has diminished my enthusiasm for infarct size, because I wonder, how is it possible that of the survivors at 35 days, then there's no additional survival benefit of having gotten streptokinase? I would have expected the curves to continue to diverge, because the reperfusion therapy would have caused smaller infarcts. Of course, they didn't measure that in a large, simple trial. But I wondered if you've ever reflected on that finding. It's central to the idea of whether infarct size, how important it is in the differences that we see here with reperfusion injury.
Yeah, that's a good point. We've seen that in a lot of studies in the past and still now. I mean, the benefit of reperfusion therapy in general is there within a few days after the intervention, and we all know that, and the curve are usually parallel with that. But this infarct size, not measured in all these trials, sort of encompasses the ischemic and the reperfusion injury. And it's quite impossible from these data to make a distinction between the two in terms of pathophysiology, between the two benefit. Of course, reperfusion therapy carries on the reperfusion injury, and there is nothing in this trial probably that would alleviate reperfusion injury, although we don't know. But it's true that it is difficult from this observation to see whether we add an additional benefit on the reperfusion injury.
I have one question, if there are no more from the audience, and it's related to infarct size and cardiovascular events, and is whether it is really important to reduce infarct size in patients with small area at risk, so patients with RCA occlusion or left circumflex. Because we are used to see many trials that the global endpoint is negative because they include all kinds of infarctions, and always there is a common circumstance that then there is a subanalysis of patients with anterior STEMI, revascularized early, and in those subgroup of patients you have positive results. So do you think these therapies apply to all kinds of STEMIs, or you would just suggest that just high-risk STEMI patients undergo these cardioprotective strategies?
Yeah, this is a very, very good question and a tough question. In fact, we see from, when we look at all these small studies and do a subgroup analysis, that we have a benefit in terms of percentage relative reduction of infarct size in all subgroup of patients. But of course, 20% reduction of an LID of an anterior infarct is something different from 20% reduction of an RCA or circumflex occlusion infarct size. And we all know that right coronary artery occlusion or circumflex occlusion STEMI patients have a fairly good prognosis. Most of them have a good prognosis. And phase 3 trials will probably tell us that I may be a bit provocative here, that there is little benefit of treating reperfusion injury, in this type of patient over time. The clinical benefit, you may need 20,000 patients to see a benefit in a few of them. While there is, I think I would put more emphasis in anterior infarct patients. We have a lot to save here. And because these patients have all been mixed together, we probably will see in phase 3 trial only devoted to LAD patients, that these patients are very severe patients, and that we have a lot to gain, although it's only, let's say, 40% of the STEMI population approximately. We have a lot to save in this patient, and we can be very, very active and save heart failure and save life probably.
Okay, thank you very much. I think we have one last question from Dr. Fernández Ortiz.
Yeah, that's a very short question. We have seen from the phase 2 studies that it seems that from the pharmacological point of view, there are two candidates to be used in the clinical arena, which is cyclosporine and metoprolol. So the question, since both drugs are acting by two different, totally different mechanisms, do you see any rationale or any sense to use, in an experimental model, both drugs together?
Yeah, that's a good question. I think we should meet. But obviously, I think the mechanisms are different, and there is, I believe in combination therapy. So I think we have to try in experimental models to see whether there can be a synergistic and additive effect of these two drugs. And on top of that, I would say that probably metoprolol given early would add more benefit because it's also targeting the ischemic damage on some part. So I think there is many reasons to try to use these two drugs in combination, at least in experimental model first.
Thank you very much. We're going to move for our next presentation. It's my pleasure to introduce Dr. Harlan Krumholz, and he has been deeply involved with this symposium for many years. Dr. Krumholz is Professor of Medicine, Cardiology and Epidemiology at Yale University, Director of the Yale New Haven Hospital Center for Outcomes Research and Evaluation, and he has a long-lasting deep interest in the evaluation and monitoring of the healthcare system performance and in the critical value of reporting properly outcomes. Due to this, he has had a great influence in evaluating agencies, including NIH, and on national and international health policies. He has been key in increasing the transparency of pharma industry, in increasing the report of trial outcomes. And he's author of more than 300 papers and many national funded trials. And in fact, he's the principal investigator of the Virgo study, evaluating myocardial infarction in young women. Spain participated in this study in what is called the IMJoven, led by Dr. Hector Bueno, and with the participation of other people here present, like Magda Eras and Ginez Sanz, as well as with the support of the NIC. So today he will talk us about myocardial infarction in young women.
Gracias. Y hola, amigos míos. Me encanta mucho estar con ustedes en esta conferencia. Creo es la mejor conferencia en el mundo, en serio. Es increíble aquí en Sevilla, gracias a Antonio y su equipo. Y para mí la información es excepcional. pero debería ser suficiente, pero es más, los sitios para estas conferencias son muy buenos, pero la gente es la cosa que es más especial. Todos los españoles son muy amables y simpáticos y gracias para nuestras de los otros países es muy bueno. Y en mi carrera es una conferencia que es muy importante. He estado aquí por 7 veces, mi 7ª vez aquí, y todas las veces son increíbles. Desde cuando era un niño en Bilbao, en mi primera conferencia, pero todo está bien, muchas gracias. Entonces voy a hablar en inglés para mi conferencia, es un poco diferente, mi asunto es de cosa de Virgo y joven, es un poco más que STEMI, pero es todo de AMI. Entonces, the question is, why focus on young women? Maybe it's not necessary. They represent a very small number of patients with acute myocardial infarction. And maybe it's possible for us just to extrapolate the information we have from the other people. I mean, why all the fuss? Why all the attention? Why spend an entire study focusing on this group? Maybe we should be looking elsewhere. That might be a question that someone might have coming into this study. And I want to explain to you why we started looking particularly at this group and why we, together with colleagues in Spain, decided it was important enough to study specifically. There were several key observations that led us to this study. Key observation number 1 was that there is an age-sex interaction. The difference in outcomes between women and men after AMI varies by age. This is the first observation we made in the 1990s that led us to think we should focus on this group. In order to do this, you have to have a very large population, and we took advantage of the National Registry of Myocardial Infarction in the United States, which had hundreds of thousands of patients. We had been looking for a time at the differences between men and women and had decided that if you look in an unadjusted analysis, women tended to do worse. But if you adjusted for the differences in their comorbidity, and particularly their age, the differences were attenuated or eliminated. And so we were writing articles at that time saying there are sex differences, but mostly because women have coronary artery disease at an older age. And that's why when you just look, you see it. But we began to think that maybe there was more to the story. And in this case, we lined up all the ages and compared men and women, women in the red, men in the blue. And we began to look far down at the side of the youngest women. And we saw that their mortality, in-hospital mortality for acute myocardial infarction, was at the very youngest age double what it was for similarly aged men. And this persisted with adjustment. And as you went up and older, actually in the oldest age, the men were a little bit higher. And this was a highly significant, what we call interaction, a statistical term, meaning that you can't just throw them all together and because the relationship varies across the spectrum. You can't just combine them and then just adjust for age because age acts differently with the different groups. We also looked at 2-year outcomes for young women. The other was in-hospital mortality. Then we looked at 2-year outcomes. This is in the Worcester heart attack study. Again, it's hard to get many younger women, but they had a study of the city, and they found, again, we found with them, again, that the younger women, even 2 years out, had much higher risk. And with age, the relationship changes. This is bringing us to think, well, there's something very important going on down here for the younger women. Now, I was pulling out a recent article from a very esteemed journal in Spain. We have the editor here with us. And it was looking at 7-year prognosis of first AMI in Spain. And it was interesting because The conclusion was the prognosis was similar in both sexes. And actually, they saw that in Spain, the longer outcomes were worse in men than women. But they didn't, I think, have enough patients to look at the difference in the interaction. But it also raises the question whether there's consistent effects across countries or whether there are specific issues in countries. Now, a second key observation was that this condition in young women is both rare and common. Rare and common. That may seem not to make sense, but let me explain. Young women with AMI are rare relative to all patients with AMI, but common relative to other conditions, meaning they're relatively small percentage. But because there are so many people with acute myocardial infarction, the total numbers actually are quite high and can rival conditions like breast cancer and others because the denominator is so large. In the US, we see that only 4% of all AMIs are occurring in young women. I'm never going to define exactly what young women are. I'm telling you that right now. But you can make up in your mind your age. But younger women, about 4%, if we have 1 million heart attacks, then we're talking still about very many people affected. If this were just a condition by itself, it would attract a lot of attention. But because it's a small percentage of all AMI, these women are virtually ignored in all of our studies. Now, don't think I'm going to have 20 key observations, only 3. This is my third key observation, is that they're rarely studied, yet they're distinctive. Part of the age-sex interaction suggests that they're different. So we say young women with AMI are rarely specifically studied, but what we know suggests that they're distinctive. Rarely studied meaning, well, first of all, sometimes we exclude them because we say women of childbearing age shouldn't be in a study, mostly of intervention studies. So sometimes we'll exclude them. If we do include them, their experience is diluted. 4%, you never see their experience in the overall picture. It doesn't influence the result to any extent. Now, so what we say is that young women are virtually invisible in cardiology. You can't find much information at all about them. And so that was the premise. The rationale for this study was to say, okay, we need to address this gap in knowledge. We need to see what's going on. Now, there is some evidence, again, that these women are experiencing something very different. This is an article from a very small number of autopsies that were conducted. But they determined that in women who die suddenly with severe coronary disease, traditional risk factors and menopausal status affect the mechanism of death. They're not specifically saying age, they were sticking on menopausal status, but they were talking about young women are more commonly have plaque erosion instead of rupture. Among those who died suddenly, thrombus formed, but not on a plaque rupture, on top of an erosion. Now, to me, I'm not a pathologist, but I'm only saying that there begins to be some streams of information. Of course, spontaneous coronary artery dissection is very important. And 70% of these occur in healthy women without risk factors for CAD. Mayo Clinic is a great center for SCAD, and I think is just beginning to help us understand some of these issues. In my discussions with the people at Mayo, there's a great thought here that many people assume you have to see a flap in order to call it a dissection. But actually, in these young women, many dissections are being missed that could be seen with other techniques. And many people are putting in stents, even though that really actually isn't what is recommended for these patients. So in all of this, we thought, well, this is worthy of our collaboration, and led by Hector Bueno and others throughout Spain, we were able to assemble a group. We have about 100 sites in the United States. CINIC sponsored these sites in Spain. What a wonderful group of hospitals from all across the country who enthusiastically participated through a coordinating center in Barcelona. And it's not easy to be very vigilant about finding and enrolling patients who don't occur so commonly. You're not geared up. It's not every day. It's only a couple times a month, even at a busy hospital. So these sites all did a wonderful job. Maybe some of you were participating directly, and you have my gratitude for that. The aims were to describe sex differences and their determinants in young patients with AMI. And I want to give just a little bit of a sense, because it's not just that we were studying young women, but the idea here is that we were trying to have a holistic view of the key determinants of outcomes in patients with acute myocardial infarction, taking into account biology, clinical, psychosocial, and societal influences. So often we're focused very narrowly in our cardiology studies, trying to be very, I say, reductionist. I'm going to talk about this some tomorrow. Very reductionist and narrow in thinking one thing causes another with regard to outcome. But truly for our patients, it's much more complex. And in this study, we're trying to understand the range of factors and how they may interact to produce outcomes. But also, we're interested in outcomes, not just mortality, not just repeat events, but function and feeling. And as you'll see in one of the studies, we'll say that I'll be describing some atypical outcomes that still may be important to patients. Now, also there's an angiographic sub-study that I just want to note, conducted by Magda and Alexandra Lansky. And they're asking about what are the sex differences and comparative prognostic importance of the angiographic data. Because angiographic data, it turns out, is very distinctive in these patients and deserves our attention as well. Our ultimate aim is to improve the care and outcomes of young women and men. We enrolled some men, 2-to-1, men to women, but we enroll men too, to figure out what can we do to improve outcomes. That's our goal, not just for the knowledge, but for the knowledge translate into action. So what I want to do now is just briefly give you a taste of 3 studies that we're doing. This is just very brief, but to give you a sense of the things that we're learning, and we're just really beginning to now get into the data. One of the things has to do with taxonomy of AMI. So you know that there is a universal classification of myocardial infarction. We've just been exposed to the 3rd iteration of the universal definition. And we have type 1, spontaneous myocardial infarction, related to atherosclerotic plaque rupture. We have 2 that's secondary to ischemic imbalance, demand ischemia, resulting in myocardial infarction. We have 3 when biomarkers are unavailable, when there may be cardiac death, out of hospital arrest. 4A, PCI, 4B, myocardial infarction related stent thrombosis, and 5 related to CABG. This is all very neat and clean and easy to see how people might be classified. But one of our questions is, when you look at young women with the diagnosis of acute myocardial infarction who meet official criteria, how well do they meet these criteria? And how well do young men and women compare in this? And we began looking and said, well, actually, almost all of these patients, by the way, undergo cardiac catheterization. They're young individuals with acute myocardial infarction. Both in Spain and the United States, most are referred for cath. Thrombosis remains the most common cause. Most with obstructive disease, if there's a thrombosis. We have here coronary anatomy, obstructive, non-obstructive, no significant stenosis. Non-obstructive means there's not an occlusion, but there's clearly stenoses. No significant, less than 50. And we see, actually I think we used less than 30 here. In the thrombosis, most is obstructive, it's what you expect. Non-thrombotic mechanisms, which include the demand ischemia, it's kind of very much evenly distributed among the different kinds of angiographic findings. But this is interesting, this unidentified mechanism, which isn't in the classification. And almost all of these are the women. Unidentified mechanism. And 22% have obstructive disease, 37% non-obstructive, 32% non-significant stenosis. But these are people who come in who you must know, young women, they have positive troponins, they can have wall motion abnormalities. You're scratching your head exactly what happened. And sometimes you have to make things up. I don't know, maybe spasm, I don't know. I don't know what's going on with this person. But they actually had something, no question. I'm not talking about people with chest pain that defies diagnosis, but they meet the diagnosis criteria. And we see this in this group, and no one, as far as I'm concerned, has talked about it much. We're interested in what's the prognostic implications and maybe what's the underlying mechanism. But what do you do with them on secondary prevention as well? Do they get beta blockers? Do they get aspirin? What do you do? There are no studies of these patients. Second, just to give you a taste, again, pre-hospital delay. Look what happens in the United States with these young men and women. So many of them present fast, but actually we have many people with delays of 12 hours or more, and the women are much more delayed than the men. I'm going to just mention, we also, when they get to the hospital, we are not as quick with young women as we are with young men. Maybe because our pretest probability is low and it takes us too long to recognize the myocardial infarction. But we have a lot of people late, and maybe this is one of the reasons young women are doing worse. First of all, also why some of the men may do worse, but many are presenting late, women more than men. But in Spain, it's very interesting. Your time to presentation is much shorter. And in fact, there's very little difference between the men and the women in Spain. I don't know, is it the health system? Is it the culture? We're just beginning to try to look and understand these differences, but we find it very interesting to be able to make the comparison between US and Spain and to try to see what the implications might be for outcomes and what the underlying causes may be. So the third one that I wanted to give you was one of the unusual sub-studies that we inserted into this study. Of course, sexual health is important at all ages, but there may be some interest in looking at young patients as well. And we had a partner who, at the University of Chicago, who had published a large study of sexuality in older individuals, and we were able to get her to work with us to develop questions for this study. And these are just a few of the things that we asked. Overall, what % of patients with AMI felt it was appropriate to be counseled on sexual matters in the context of the AMI care? So if we believed in patient-centered care, the first question to patients is, would you feel it's appropriate for your doctor to talk to you about sex after an MI? Is this something that you think is the right thing? Now, when we started talking about inserting these questions, I can tell you many of the investigators said, our patients don't want to talk about this. And if you interview them in a study, they will hang up on the phone. They won't want to talk to you about it. In fact, all of the patients, almost all the patients engaged in were appreciative of these questions. And what they answered of the women, 75% wanted to talk about this or felt it was appropriate, more of the men. What % of patients actually received counseling? Report that they received counseling about this. 12% of the women, 19% of the men. So many more patients are reporting, and by the way, this is a cold question out of nowhere. Do you feel it's appropriate? You can imagine if it was handled within the context of an office, these feeling it's appropriate might even be higher. They've maybe never had the chance to talk about it. But actually, when you ask them about whether anyone did talk to you about it, almost no one has. Who do you think is more likely to initiate the discussion about sex after MI in each country? Physicians or patients? Maybe which country has doctors who are more timid about asking questions about this? So it turns out in the United States, patients are more likely to bring up the topic than doctors. In Spain, remember, not many people are bringing up the topic anyway. So it's not that so many are, but actually the physicians are more commonly the ones. When they do discuss it, it's been started by the physician. Who's more likely to be told to restrict sex after MI, women or men? So, assuming the same kind of MI, when the doctor makes a recommendation, are they more likely to tell the men or the women to restrict sex? Or the same? They tell men and women the same. They don't pay attention. In the US, they're more likely to tell men to restrict sex. In Spain, they're more likely to tell the women. I'm not going to say whether the women are more active here, or I don't know, heart rates go up higher than the US. They're making, I'm really going to get into trouble if I get very far on this. But it's interesting just to be able to be exposed to the perceptions and ideas. And this is what the numbers are actually. Physicians recommend to limit sex. In the US, it's less than 20%. It's actually about the same. I think actually I should have pasted that a little differently because the men should be slightly higher. But we're much lower. In Spain, there's many more recommendations to limit sex after MI. And the recommendations in the guidelines actually are not very strong at all. Other recommendations could have been heart rate or amount of activity versus this was one of the categories was limit sex completely. These are reports from patients. So other topics that we're addressing, it turns out that young women have many more traditional risk factors that are unaddressed before their acute myocardial infarction. They have more depressive symptoms, often untreated. They have similar levels of social support, but they have worse health status, baseline and long-term. Their functioning is worse when you ask them with the official sort of instruments that measure both their symptoms and what they're able to do and what limitations they have because of their health. They have more comorbidity, higher stress, young women, more misdosing of medications, and more delays in treatment when they become available. So we're identifying all these things that are somehow connected that may vary by men and women, and we're going to be linking them with outcomes. But I think that this is turning into a study, in addition to one that's focusing on young women, that's studying the complex interplay of factors that influence a wide array of outcomes. It becomes, how does everything fit with everything else? And how does it ultimately affect not only death and events, but how people feel, how they function? And even with the sexual health, we have 1-year follow-up to say, were there differences? Did the counseling matter? How did it affect people? And it's not just about opening arteries, with all due respect to all of the good work that opens arteries, and not only to do with secondary prevention medications, with all due respect to all the good work on that, but it's about understanding the big picture. And it's, like I said, it's not just about the little things we do, but understanding the social context and their psychosocial status and a lot of other issues. By the way, also we're studying biology, and these people are getting exome analyses, so we'll be able to bring biological data into this as well. And as I said, not just about mortality, reinfarction mortality, but more. The study is also about giving these patients a voice. To this point, they've been silent in our literature. We haven't been able to bring forward their perspective, their experience, information about them. Now, because of the work in Spain and the US, we hope to give them a voice, to give studies that will help support our treatment of them, and to begin to give a literature that will help improve their care. So, gracias a joven y todo gracias a ustedes. Thank you.
Any question from the audience? Dr. Cosme García.
Okay. I'm Cosme García from Barcelona. Thank you very much for your excellent presentation. And only want to make two different comments, or one comment. I think the worst prognosis in women about myocardial infarction could be due to different mechanisms. Or the classical one that women are poorly treated during the hospital stay, and in our area this difference has nearly disappeared. And apart from that, I think we have several drugs, several therapies, several procedures to treat obstructive lesions. Okay, but in a woman, it could be a different pattern of coronary lesions with less epicardial lesions. It could be all the arsenal, all the drugs are related to treat the new antiplatelet therapies with new stents, drug-eluting stents, and something like that. But I think it could be in women with a different pattern of coronary artery lesions. Could be, I think we don't have enough information about this kind of disease in women. I want to ask your opinion about this topic, please.
Yeah, I think it's a terrific point, and it actually goes beyond study of young women. And again, I'm going to mention this tomorrow, but our taxonomy, our classification is so crude. You know, we enroll people in trials, and we're bringing together very different kinds of people. And we get a result, and then we say, okay, our guideline says if you have AMI, you should be treated this way. But we really don't understand responders and non-responders and the heterogeneity of pathophysiology and all these other factors, which are amplified in young women because it's enriched for people with a wide variety of underlying causes, some of them not connected with atherosclerosis or directly related to risk factors, others are. So we see actually many of these patients have untreated risk factors. And many of them do have what appear to be ruptured plaques, but many of them don't. And just as you're saying, for us to personalize the care, we need to understand better who is this individual? What's the likely underlying cause? What's the context of their life? And how can we get a personalized approach to help them do better? I think it's a very good point that you make.
Thank you for your great presentation. I have one question regarding the approach to reperfusion. Is there any data suggesting that primary PCI systematically applied in STEMI could decrease or attenuate the differences between young men and women in prognosis? Because it's a question, I don't know. It's because all the registries, most of the registries are done in years when you have mixed between fibrinolysis and primary PCI, and we know that thrombolysis maybe could be deleterious in some of the pathogenic mechanisms in women, no? And do you have any data suggesting that maybe primary PCI as a systematic approach to reperfusion could really balance the prognosis of women? Because you also could recognize easily, promptly, the real mechanism of the infarction also. So not only for the PCI, but also for the differentiation of the different pictures of models of infarction in young women.
Yeah, I think it's a very good question, and this study is not so well designed for that because it really was designed to start at get the patients who survive the early period and then to look long term, being able to interview them and understand their lives. You really need a study that starts on admission to look at this, but there are clues anyway, that the fact that they delay more, at least in the US, that the delay once they get to the hospital is longer in the US, and we're looking at it in Spain as well. You know, even if you do primary PCI, you may be having problems that lessen the benefit, but you know, we're not in a good position to answer that question yet, and we will need more studies. And we need to be coordinated and organized so that even for these patients who are not so common, that we're ongoing collecting the information. I don't think it's actually so burdensome to continue even from admission and then saying we want to learn about this, but it's a very good question.
Kjetil Sunde from Oslo, Norway. Thank you for your excellent talk, very interesting topic. We actually came across the same problem last year when we published a study among cardiac arrest patients admitted to hospital in 3 hospitals in Norway, 800 patients, and we actually saw that women received less frequently angiographic procedures, less frequently hypothermia, and the survival was also lower among women. So this is actually something that we have to look closer into. And there are some, I know it's actually at least a group in Texas that are doing studies with estrogens. And do you have any, what are your thoughts about hormone therapy, estrogens or whatever?
Yeah, it's certainly a very controversial area. The concerns are the older estrogens, at least that were tested, may actually paradoxically increase risk for some individuals. The newer ones, it's some controversy. You know, I think the way that we're using it now is there needs to be a strong indication not for prevention but for symptom treatment for people who really find life intolerable and, you know, or are immensely uncomfortable through menopause. And then you know what you're using it for. But for any other purpose, I think that there's no enthusiasm for going in that direction. But I agree with you. I think this is a systems problem. It's almost as if we spend so much time being surprised that a young woman has heart disease, particularly acute myocardial infarction, that it throws us off our usual timing in terms of caring for people or thinking things through. And We need to be ready to know that these happen. And we can look in both our countries and see in busy hospitals a couple times a month, somebody would come in. And maybe once a month, even sometimes every other month, but they would come in. And everyone has to be ready to say these patients need to be treated. Once we recognize, bang, they need to be treated thoroughly. And then we need to understand which category they fit into. Are they a ruptured plaque? Is it SCAD? I mean, what's going on? And we need to work quickly to try to figure that out. It's disturbing in the cardiac arrest patients, of course, because all of them should have thorough studies and hypothermia if possible. And, you know, where we see those kind of gaps, they need to be addressed immediately. There's just no reason to have that kind of disparity in treatment, especially as we know there may be disparities in outcomes.
Thank you very much, Dr.
Thank you.
Hall, but we have to continue with the third and last presentation. Dr. van den Heuvel is an interventional cardiologist in the University Medical Center Groningen, the Netherlands. He has made important contribution in the area of primary PCI with studies of thrombus aspiration during primary PCI and the use of intracoronary administration of atezimabs compared with intravenous administration. And now, very recently, his group has published, I think that last month, in The Lancet, the GIST-3 trials about the effect of metformin after acute myocardial infarction in patients without diabetes. He has a huge experience in this topic of today, and he's going to speak about a hot topic nowadays, the reperfusion therapy for STEMI, pitfalls and potential on networks.
Thank you, Mr. Chairman, for this kind introduction. And thank you for the organizing committee for the invitation, for being here at the symposium in the beautiful city of Sevilla. The first slide shows you the hospital it used to be. And as you can see at the transportation facilities at that moment, it was not really prepared for a primary PCI. That's why we rebuilt the hospital. Well, we tried. Okay. Yes, we rebuilt the hospital. Nowadays it looks like this. The University Medical Center Groningen, it's in the north of the Netherlands. Well, the topic of my presentation, the pitfalls and the potential of networks. Well, the pitfalls, maybe you can imagine, do you have to be a samurai to work in a STEMI network? Well, maybe I give you the answer later. While preparing this presentation, I did a search on the internet, STEMI network, Spain, and one of the first hits was the SFL, the Stand for Life project. It's a project initiated by European Society of Cardiology. And almost 2 years ago, there was a session held within the annual meeting of the Interventional Cardiology Working Group of the Spanish Society of Cardiology. I show you two of the presentations. Well, my Spanish is not as good as the speaker formerly, but Dr. Joyela, he depicted the results of the Actua network in Cantabria. And in this STEMI network, there has been a reduction of 81 minutes in door-to-balloon time and a reduction of 48 minutes in pain to first medical contact. And that was in 5 years reached. And the number of patients treated by a primary PCI increased from 45 to 78%. The second project was the IAMCEST, which was presented by Dr. Avanzas from Oviedo. And within 2 years, from 2009 to 2011, there was an increase in 446% in the number of patients treated STEMI with primary PCI. So I was wondering what am I going to tell new to the Spanish cardiologists? Well, maybe you can tell me afterwards, after my presentation. First of all, the STEMI decision matrix. The focus of my presentation is on the right above the regional systems of STEMI care. I'm not going to discuss the primary PCI versus thrombolysis or rescue PCI, of the radial versus femoral access routes of thrombus aspiration. I'm focused on the regional systems of STEMI care. An important slide in this topic is the STEMI chain of survival. This chain consists of four rings. First of all, the early symptom recognition and call for help. That is the patient's delay. The activation of the emergency medical system, and they can can start the treatment, the pre-hospital diagnosis and treatment. In hospital, it's about the emergency department evaluation and start the treatment, and at the end is the reperfusion therapy. As you can see, it's a small part of the whole chain. What do the STEMI guidelines say about the STEMI protocol, STEMI network? Well, the guidelines are based almost solely upon the clinical trial evidence, and therefore frequently do not acknowledge the realities of real-world clinical practice. Failure to apply the guidelines is rarely caused by the lack of knowledge of their content, and typically failure is related to financial concerns or organizational difficulties. Well, a good STEMI network, an integrated strategy to optimize STEMI patient care must address each step of the patient's journey. Think of the chain of STEMI survival. So from patient symptom recognition to the first diagnosis and treatment, including the ambulance, to rehabilitation and secondary prevention. And the guidelines must be applied within specific regions based upon the realities of local medical resources and geographic realities. When you live in a country with, for example, mountains, when the patient lives on the top of a mountain and experiences STEMI, you have a problem. It's another story than in the Netherlands, which is quite flat. We have one mountain, it's almost 200 meters, so that's not a problem. Well, the first ring is the patient and the family education. Enhance efforts with primary prevention. This will decrease the frequency of the first events of the STEMI. The public awareness of the symptoms of acute ischemic heart disease. This will decrease the patient-related delay. You will activate the emergency medical system. Very important. Public education in CPR and expansion of automated external defibrillator programs. The second potential of a STEMI network is a pre-hospital diagnosis. The public access to a single call number for emergencies, which number to dial, education of emergency dispatch personnel, pre-hospital 12-lead ECG, and transmission to a hospital where someone decides is the STEMI or not STEMI ECG. And this is accompanied with pre-hospital screening checklist and pre-hospital treatment algorithms. And further, also the in-hospital diagnosis of the STEMI is important because not all the patients will arrive by the ambulance. Some patients refer themselves and they present at the first aid department. And also their education of the triage personnel is very important. Symptom recognition, an early 12-lead ECG, and very important communication of these findings immediately. When they see a STEMI ECG, call the cath lab personnel. There's a STEMI patient, so there's no time lost in treating the patients. When the networks works as meant then there's a rapid confirmation of the diagnosis, activation of the cath lab, and preferably done at the time of the first medical contact, rapid transport via the ambulance, and implementation of bypass protocols of hospitals without specialized cath lab capability. When you look to this flowchart, then you think, well, that must not be hard to introduce a STEMI network. The thick arrows, they present the preferred patient flow. The patient, they call the number. The EMS is activated. It's the pre-hospital diagnosis, triage, and the care. The ambulance transported the patient not first to a non-PCI capable hospital, but directly to the PCI capable hospital. And the dotted lines, there are the lines to be avoided, that the patient is first transported to a non-capable hospital. I shall show you later why. Well, I have only mentioned till now the potentials of a STEMI network. There are also pitfalls, and the pitfalls, I mean barriers to implementing and maintaining a STEMI system of care. First of all is the patient delay in seeking medical assistance. When the patient delay is very long, well, you have a little support of the whole STEMI network. The communication issues between multidisciplinary teams, financial barriers to support required staff, training, equipment, technology and medications, lack of agreement of optimal approach among regional opinion leaders. And also the transportation barriers, regional legislation, or lack of an experienced 24/7 primary PCI capacity. Another pitfall is the competition between doctors, between hospitals. And not all networks are created equally. Competition for patients within regionalized care can impede their effectiveness. It can motivate collaborators to participate, but it may also present obstacles as hospitals or physicians don't necessarily want to help their competition. And competitive networks in the same geographic region, well, I don't think that is a very good situation, but of course it happens. So cooperation, I think that is the most important for an optimized STEMI network. And this cooperation was introduced, well, almost 10 years ago by Professor Felix Zijlstra in Groningen. Nowadays he works in the Erasmus University Hospital in Rotterdam. And this series of slides is, well, almost 8-9 years old, but the STEMI protocol did not change very important. This is a map of the area of Groningen. Groningen city. You see Delfzijl. Delfzijl has a hospital, and Winschoten is just outside the map. It has also a hospital. The red flag presents a patient with chest pain, 10.10 hour. Well, the patient has some time needed to think, well, what is happening to me? And then he calls 112. The ambulance arrives almost 10 minutes later. They make a 12 record ECG, and they see the myocardial infarction, inferior wall. The patient is already transported, and the ECG was faxed by then. Now it's on a laptop by a kind of mail sent to the cardiac care unit of the University Medical Center in Groningen. And the ambulance starts driving in the direction of Groningen. There is some communication with the nurse of the cardiac care unit. And when they decided, well, the patient fits into the protocol, there's ST elevation, Then the pre-treatment is started. Is aspirin, heparin, and nowadays is ticagrelor. 11:15 arrival at the University Medical Center Groningen. It's a large hospital, so 30 minutes later the patient arrives at the cath lab. 10 minutes later, coronary angiography, the right coronary artery is occluded. Balloon, 11:45, and reperfusion. It's a nice blush. So the total ischemic time is 95 minutes. I think that's a good result of the protocol. What should have happened when the protocol did not work? I think the patient would have been transported to the hospital in Delfzijl. And what happens then? They make an ECG, they see the STEMI infarction, and then they transport the patients to the hospital in Groningen. Well, what happens then? To show you this slides. We started these patients in 2 years, more than 1,000 patients with an STEMI. And when you look at the red patients, 127 patients, was 15%. There was an inter-hospital transfer due to failed pre-hospital diagnosis, which meant primary PCI. So those patients were first transported to the non-capable PCI hospital. And what then happens, the call to first medical contact is the same. They arrive in the hospital just at the same time as in the hospital in Groningen. But you lose some time. The total system delay, door to balloon time, and total ischemic time, it's longer in the inter-hospital transfer patients, the red lines, as compared to the pre-hospital diagnosed patients. So you lose some time, and what means this for the patients? Well, the mortality is less in the patients which were transported direct to the cath lab. Quite a difference. Well, is it maybe better to have all the hospitals the capacity for primary PCI? I don't think so. This slide shows you that in every hospital, which how you look at the figures, the more primary PCIs per hospital, less than 36 or more, 60 or 60, less than 100 of 100. The results, as look to the 30 days mortality, is always lower in the high volume hospital. So primary PCI is a dominant reperfusion strategy. As I said, regional STEMI programs have diminished reperfusion treatment delay, but timely primary PCI remains improbable for many, maybe in some countries, think about the mountains, or few. The geographic reality plays a very important role. But primary PCI is a complex, multidisciplinary and time-sensitive intervention, and it's very important communicate with the colleagues from the other hospitals. So maybe this is why I give you the answer, well, do you have to be a samurai? I think cooperation is more important. Maybe you recognize the person in the green shirt. Cooperation is very important. I have a few slides on other kind of pitfalls. Atherosclerosis is the most common cause of the myocardial infarction, but also other potential etiologies are increasingly recognized. It can be epicardial, microvascular, or neither. Some of those other etiologies, Prinzmetal's angina of myocardial bridging with angina pectoris, apical ballooning syndrome, the Takotsubo, or the spontaneous coronary artery dissection, coronary anomalies, the vessel is between the great vessels, the aorta and the main pulmonary artery. Well, are those patients a problem for the STEMI network? I don't think so. While doing the coronary angiography, you can also make a diagnosis what is wrong with those patients. But the patients are really a problem for a STEMI network, not because it's a large number, but for the outcome when it goes wrong. If, for example, patient without a dissection, this article describes 3 cases of patients who came into the hospital sent in by the STEMI protocol, and later, well, it turned out to be that the coronary arteries were not occluded, but there was an aortic dissection. And the title of this page here is the potential harm of antithrombin and antiplatelet therapy. Well, there is a potential harm, and one of the patients was treated by me and do not live anymore. But on the other hand, while making this diagnosis, you cannot do an echo or a CT scan. You see this dissection in every patient because there is time delay. But when you have some clues, when you think about it, I think it's very much better first to do a CT scan. These are the last slides. Nightmare of the STEMI protocol. And the nightmare, I think, are the late complications which come to the cath lab and present as a STEMI. This is the ECG of a patient 70 years of age from 1 week ago. And the story during 2 hours, chest discomfort, dyspnea, a healthy man before. On the ECG, well, maybe a little elevations, but probably a posterior myocardial infarction. So the patient was accepted for a primary PCI. When the patient entered the cath lab, so hypertension, 85. We gave him some administration of some fluids. The blood pressure increased to 100 millimeter mercury. And we decided to go on with the catheterization. Because the patient was from tachycardia, I thought, well, it can be the right coronary artery, most for example, because of posterior wall infarction, the circumflex. Well, this was the first, well, you saw me, stops now. Well, he's again. Was I mistaken? Was it the right coronary artery related infarction? We went to the left, and then I saw the circumflex was occluded with a sign of a large thrombus. Thrombus aspiration was performed. A large amount of mostly red thrombus was aspirated. There was a stent included, and there was a good flow. But meanwhile, the blood pressure decreased again to 75 millimeter mercury systolic. Then we decided to bring in an intra-aortic balloon pump. Whether that is a good idea, you maybe heard in the next session. But the patient developed pulmonary rills. By listening to the heart with the stethoscope, you heard no murmurs. But the oxygen saturation they fell down to 82%. So the patient had to be intubated. And then I thought, well, what is going on? Meanwhile, the family arrived, and his wife told me, well, 4 days ago, my husband experienced for several hours severe chest discomfort, pain, and well, after 3-4 hours, the pain was more, he was able to handle it. He was not feeling too well, but he did not go to the doctor. That was 4 days ago. So I think of the evening of this STEMI protocol, the patients that have the result of a late complication of a myocardial infarction. And the picture is not too well, but it's the only pictures I have. But maybe you can see there's signs of a papillary muscle rupture. Yeah, it's not the best picture. There was a very severe mitral regurgitation. The patient was operated, of course, of aspirin, ticagrelor, Reapro, and glycoprotein 2B3A antagonist. The patient received a mitral prosthesis, severe bleeding complications, and 1 day later the patient died hemodynamically, cardiogenic shock, multi-organ failure. Well, it happens. That is a nightmare, I think, for an intervention cardiologist. Thank you.
Thank you very much, Dr. van der Heuvel. The paper is open for discussion. We have a question in the second row.
Thank you. Marcus Flather from England. There was a wonderful overview of the challenges of delivering a complex therapy to patients in a rapid fashion. One aspect is actually the availability of skilled interventional cardiologists, which it was buried somewhere in your talk. Can you talk more about that? Because in terms of a training need, in terms of how we're going to deliver this in the future, this is actually a very important rate-limiting step, I'm sure in Holland, also for us in the UK. You know, to run a 24-hour STEMI service, you need probably 8 interventional cardiologists at least, and also the assessment of the patient before going to this primary PCI. They do need to see an experienced cardiologist before the procedure, otherwise you might see patients on the table with all these other syndromes that actually make the intervention potentially very dangerous.
Your first question, we have 7 intervention cardiologists in our hospital. I think that's enough. In the Netherlands, there is the minimum volume. There are 4 interventional cardiologists, and the minimum volume for each center to do 600 PCIs yearly. So each interventional cardiologist has to perform 150 PCIs yearly. I think that's an acceptable, good volume to keep the experience in your fingers. Training the intervention cardiology takes 2 years. 2 years to be a fellow, and then the first year the second operator, and then you step for the first operator, and you have to perform 250 PCIs within 2 years. Well, those are the minimum volumes. But when you start training a fellow, you know before does he has the skills, is he a little bit handy? But it takes 2 years. And after 1 year he is on call with the experienced cardiologist, and during out office hours he is standing at first operator but the supervisor. In this protocol, the nurse of the cardiac care unit, eventually with a fellow, they decide whether it's a STEMI ECG or not. And the patient is not seen before by a cardiologist. Those are choices you have to make. There is not an experienced cardiologist into the hospital. There is a fellow into the hospital on call. Sometimes the last patient I presented, it happens, and well, I've seen this before, but that was a very loud murmur. And then I decide first an echo, and then we see further. But well, after all, I think the patient was that deep in shock. The heart sounds were very weak, so the murmur must have been also very weak.
Okay, I have one question. It wasn't clear to me whether in Groningen, in your area, all the electrocardiograms are transmitted to the coronary care unit, and you have to accept the patient for primary PCI, or by contrast, some cases they can go straight without notifying to the coronary care unit?
No. The contact is with the coronary unit, and then the cath lab team is informed, and the patient, when he arrives at the hospital, and the cath lab team is into the hospital, they come straight to the cath lab. Maybe there is another STEMI patient in the cath lab, then first the patient go to the cardiac care unit. But the nurse at the cardiac care, he decides when there's no doubt, the patient can come.
And do you have, if there is any information regarding the differences in pre-hospital treatment in those services with physician-man ambulances versus technicians or versus paramedics?
Some data on
the presence of doctors in the ambulance compared, for example, in Spain, usually most of the ambulances they have doctor in the ambulance, but it's not the case.
No, there are no doctors in the ambulance in the Netherlands. No doctors in the ambulance, but the ambulance workers, they are trained. They did an extra training, looking to the ECG, and very easy to make contact when there are in doubt. They fax or they send the ECG to the coronary care unit. There's always a doctor, a fellow, who can look at the ECG. When they are in doubt, they first come to the first aid department, and otherwise they send the patients to the cath lab.
Okay, we have one last question from Dr. Calvo.
So thank you very much for your exciting lecture. So just a question to avoid the interventionalist cardiologist nightmare. It's about introducing the routine echocardiography in the ambulance, for instance, point of care echocardiography, handheld. What do you think about it?
Good point. When it's financially seen possible to have one of the ambulance, when you have a doctor, train him to make an echocardiogram. You can, the late STEMI complication will not present as a STEMI in the cath lab. It's a good one. I think there are some financial problems by introducing that, but well, very good suggestion.
Okay, I think we are going to close the session. So we have had a very, very interesting session. First, we have seen from Dr. Michel Ovis that reperfusion injury is really important and we should focus our attention into that. Then we have Dr. Krumboldt opening our minds on the importance of better studying the myocardial infarction in young women, the population that is invisible in clinical trials. And finally, we have seen the importance of the chain of survival from Dr. Van der Heuvel talk. So now we close the session. Thank you very much. We go for our lunch, and then in 1 hour we'll come back for the next session. Thank you.
Thank you very much.